Welcome to AETCM, the emergency medicine channel. Today, let us discuss about encephalitis. Encephalitis means inflammation of brain. Meningitis means inflammation of covering of the brain. That difference you should understand before starting the session. Most of the time, encephalitis is produced by mostly viral infections, some autoimmune diseases, malignancies, immune-mediated problems like that. Rarely, bacteria also can produce encephalitis. But meningitis is predominantly produced by bacteria, some tuberculosis, fungus, all these things. So encephalitis means mostly it is viral encephalitis. Meningitis means mostly it is bacterial, tubercular, fungal, like that. But most of the time when we treat a patient, this encephalitis and meningitis can have features of encephalitis or features of meningitis can be in same patients, same patient. So encephalitis is a non-suppurative inflammation of brain, whereas meningitis is a suppurative inflammation of the meninges. So here there will not be any pus, but brain as such is inflamed. Most of the causes of encephalitis, we have already told, it is viral. Viral is the most important. That we see large number of herpes simplex 1 virus. Herpes simplex 2 is mainly genital infection. Herpes simplex 1 is mainly in the brain, or it can be there in other areas also, but that is the one virus which produces predominantly viral encephalitis. Then other diseases like measles, mumps. Mumps can have peripheral features, measles also can have peripheral features. Most of these diseases are very classically seen in children. Poliomyelitis is a chronic encephalitis. It can produce weakness, but nowadays it is almost eradicated because of the vaccination protocol. Japanese encephalitis is seen in some parts of India. Clinical features of encephalitis is almost similar, but Japanese encephalitis is seen only in some areas, endemic areas. It is not a disease which is seen everywhere. Varicella zoster encephalitis, Epstein-Barr virus encephalitis, then HIV encephalitis. HIV as such can produce encephalitis, or opportunistic infections in HIV can produce encephalitis. Another infection which was recently reported in India is Nipah virus. So that also produces encephalitis. Many other viruses, including dengue virus, also can sometimes produce features of encephalitis, but they are not primarily targeting the brain, so they does not come under the viral encephalitis. As a part of general disease, they can have meningism features or encephalitis features. Most of the patients who is having fever due to any reason can also have features of encephalitis without actual inflammation of brain. You can have, the patient can have fever, severe headache can be there. Altered sensorium is a very important feature. When we compare with meningitis, this is a typical feature of encephalitis. Altered sensorium is not seen in meningitis. They can have fever, headache, but altered sensorium is almost a feature of encephalitis. Now, whenever there is an inflammation of brain, you know that the cranium is a closed chamber. So whenever there is an inflammation, it will swell up, the brain will swell up, so that the space in the cranium will come down, free space will come down. That increases the pressure in the intracranial compartment. So most of these patients who is having severe inflammation of brain, they can have increased intracranial tension features. So classical findings are severe headache, vomiting, papilledema, that should be examined. We should examine the patient's fundus, optic fundus. For that, patient can have hypertension, bradycardia. So bradycardia is an important clinical finding in a patient who is having encephalitis or head trauma. If the patient is having bradycardia, think that there is a high possibility of increased intracranial pressure. Focal neurological deficit sometimes can be there, but it is mostly seen in meningitis than encephalitis. Many patients can have seizures. So inflammation of brain can become an irritant lesion in the brain that can produce seizures. So some specific clinical features like herpes simplex encephalitis, herpes simplex 1 encephalitis, there will be involvement of the temporal lobe of brain, so they can have psychiatric manifestation. They have altered behavior, all these things. Sometimes it will be falsely admitted to or without knowing the proper diagnosis, these patients may go to psychiatric ward. So psychiatric syndromes are classical features of herpes simplex encephalitis, especially herpes simplex 1 encephalitis. It can lead to olfactory, gustatory hallucination, anosmia, personality changes, memory disturbance. In that, personality changes are very, very important. These patients can come with severe altered behavior to emergency room. Some patients can have neck rigidity. Neck rigidity is not a typical feature of encephalitis, it's a feature of meningitis, but many patients can have meningoencephalitis, so they can have neck rigidity. Now, parotid enlargement, painful parotid swelling is a classical feature of mumps. Here also, you can have altered behavior. Mumps encephalitis can be there. One of the important CSF finding will be their glucose level will be slightly low comparing to other viral encephalitis. Most of the viral encephalitis, CSF glucose will be normal, but here it will be slightly low. Hydrophobia, aerophobia, pharyngeal spasm, difficulty in swallowing, difficulty in taking water, all these things are suggestive of rabies. Vesicles in dermatomal pattern that uh, points towards varicella zoster virus. Sometimes patient can have skin lesions in a peculiar area, especially like face, trigeminal area. Then that patient, if the patient is having altered behavior, seizures, you have to think about varicella zoster encephalitis. Now, a few words about HSV encephalitis. It's a necrotizing lesion in the temporal lobe with the patient can have altered behavior, coma, and some patients can have epilepsy. Bell's palsy can be there. That is because of the seventh cranial nerve involvement. Other cranial nerves also can be involved. Cranial nerve polyneuritis, transverse myelitis. Suddenly, patient can develop weakness on both the lower limb with a sensory level, with a painful lesion above the sensory area. Guillain-Barré syndrome-like features can develop in some patients. We can do CSF PCR for HSV1. MRI brain may show temporal lobe lesion. These are the classical findings in herpes simplex virus encephalitis. Remember, we start acyclovir for all patients who is having encephalitis, but that is mainly targeting only herpes simplex virus. Other viral infections, acyclovir may not be useful. Even then, when we are not getting a proper diagnosis, if you are suspecting viral encephalitis, we start acyclovir. Once you rule out herpes simplex virus, you can even stop the drug. Japanese bee encephalitis is an endemic disease. Only in some pockets you can get this type of diseases. Flavivirus is it's a group of virus. Among that group, you get Japanese bee encephalitis virus. It is mainly transmitted through mosquitoes. Reservoirs are mainly pigs. One of the important encephalitis which transmitted from pigs are Japanese bee encephalitis. Patients can have fever, body pain, anorexia, vomiting, photophobia, headache, brainstem encephalitis, seizures, multifocal CNS involvement, hyponatremia, extrapyramidal manifestations. All these things are feature of Japanese bee encephalitis. There are vaccines available to prevent this infection. Nipah virus was reported in Kerala previously. These patients also can have typical features of encephalitis. Other than classical presentation, they can have cerebellar brainstem signs, myoclonus, hypertension, and tachycardia, maybe due to autonomic dysfunction. Now, CT or MRI can be done in all encephalitis, but MRI is better than CT in encephalitis. There is no need of contrast in CT or MRI to detect encephalitis, but to detect inflammation of the meninges, you need to have contrast. So most of the time we ask for CT contrast or MRI contrast to detect meningoencephalitis. If we don't have facility for MRI or contrast enhanced CT, a plain CT also will be enough to make out whether brain is inflamed or edema is there. So depending on your sender, we can go for MRI with contrast or CT with contrast or plain CT, like that. Temporal lobe involvement is strongly suggestive of herpes simplex virus. Temporal lobe epilepsy can be there, altered behavior can be there, and if the temporal lobe is involved in contrast enhanced MRI, then that will be a classical finding for herpes simplex virus encephalitis. Other viruses like Epstein-Barr virus, HHV6 can also produce similar type of finding. Varicella zoster virus also can have similar finding. Other findings like patient can have raised ICP. So the sulci, gyre, that demarcation will be lost. There will be increased pressure or fluid overload in the brain. Findings can be there, that will show the MRI finding afterwards. Midline shift is another important feature. So if one side of the brain is inflamed, then there will be edema on that side, then midline can be shifted to opposite side. That is classical finding. Sometimes the raised ICP can lead to corning and brainstem dysfunction and death. Thalamus basal ganglia involvement may be seen in encephalitis due to respiratory viral infection, Creutzfeldt-Jakob disease, that's a chronic infection, arbovirus, tuberculosis. Tuberculosis is a bacteria, but sometimes it can present like viral infection. That is a problem. Most of the clinical features may look like encephalitis in later stage of tuberculosis, but initial stage it looks like bacterial meningitis, because neck stiffness only will be the feature in that. Here you can see temporal lobe involvement in MRI. Prominent lesion in the right temporal lobe with gadolinium. There is an enhancement predominantly involving the right medial temporal lobe. So if this patient come with severe behavior abnormality, short history, and altered behavior, seizures, then you should suspect herpes simplex encephalitis. And when you do LP, we have to ask for HSV1 PCR. Now, every patient with brain infection, whether it is bacterial, viral, fungal, tubercular, or even malignancy, autoimmune, we have to do lumbar puncture study. Lumbar puncture will be done to take the cerebrospinal fluid, and we will be doing analysis on this fluid. So if we see the study pattern in viral infections, CSF study, CSF can be clear. If it is a bacterial meningitis, mostly pus will be there. Even under microscope, or if you are not seeing with your eyes, you can see the pus cells under the microscope. Opening pressure is increased, that is because of the raised ICP. Proteins are classically elevated. Any type of inflammation in the brain that can elevate the protein. Sugars are normally not reduced in viral infection, whereas in bacterial infection, sugars are utilized by bacteria and it will be reduced. But viral infections like HSV, mumps, and some enteroviruses, it can be reduced. Classically, it is explained in mumps encephalitis. Mumps and encephalitis can mimic like bacterial finding, bacterial meningitis finding. Their sugars are classically low. Cell counts are always increased, but they are predominantly lymphocytes. So lymphocytes are seen in viral infection, fungal infection, and tubercular infection. But if the history is very short, and if when you are doing LP, lymphocyte predominance always point towards a acute infection like viral infection. If the history is longer, then you have to suspect bacterial like tuberculosis or fungal. CSF PCR is done in HSV. Sensitivity is 98%, specificity is 94%. Now you can see here the differentiating feature of CSF study in various types of brain involvement. Now we'll be seeing only viral here because last class in bacterial meningitis we have explained that in detail. Cell counts will be classically elevated, but most of the time what we are seeing in our clinical practice within 1 or 2 days of viral encephalitis, the cells are slightly elevated, maybe 250 to 500, that's all. But book says 10 to 2000 lymphocytes can be there, but most of the time in clinical practice you may get around 250, 300 like that. Glucose mostly normal, but in mumps we have already seen mumps it is low. Proteins are elevated in all types of inflammation, whether it is bacterial, fungal, tuberculosis, everywhere it is elevated. So it is slightly elevated here, but it is very high in bacterial. So that is the difference between bacterial and viral. Gram stain is negative because gram stain we are looking for any bacteria present in the CSF, that will be negative here. Now CSF can be sometimes normal in some of the viral encephalitis, but clinical findings are very important. And mononuclear cells usually predominate. That means lymphocytes are mainly seen in encephalitis. Neutrophils can be present in early phases of the disease, but most of the time when we get the patient, that will be the second phase of the disease. Some viruses like West Nile virus encephalitis, there will be neutrophil predominance in the CSF, but in India it is not very common. Eosinophils are also seen in some of the infection, but classically eosinophils are not seen in viral infections. Very rarely you get eosinophils in the viral infections. Now, other investigation in emergency room, we can do ABG. Hypoxia can lead to encephalopathy sometimes because of the aspiration, lung infection, all these things. Sugars can be hyperglycemia or hypoglycemia. That depends on the clinical scenario. Creatinine, blood urea should be done. We have to rule out other encephalitis also because hypoxic encephalopathy, hypoglycemic encephalopathy, uremic encephalopathy, hepatic encephalopathy, electrolyte imbalance, all these things should be ruled out. EEG is one investigation which will tell you where is the focus for the seizure. In a focal temporal lobe spikes on a background of slow or low amplitude activity, general low or slow amplitude, only temporal lobe activity spikes are there, then it indicates HSV encephalitis. Then Japanese encephalitis, you can see ELISA test, you can look for ELISA test. Management in emergency room always take care patient's airway, breathing, circulation. So every patient we have to follow the same steps. If the patient is having seizures, anticonvulsives should be started like phenytoin, fosphenytoin, phenobarbital, levetiracetam. Depending on the scenario, you have to start. Raised ICP should be managed with dexamethasone. That's a steroid which has got very good penetration to the brain. So that can be given. Hyperventilation, if the patient is on ventilator, you can do that. Mannitol also can be given. 20% mannitol can be given as a bolus. We should remember that mannitol should be given as a bolus. Many times what we can see the wrong practice is mannitol is given as an infusion. That is not correct. If you want to reduce the ICP, you have to give it as a bolus. If you are giving slow infusion, it will act as a diuretic only. So that you should remember. 3% saline also can be given to keep the sodium level above 145. That will be very difficult to practice. But if you try to keep the sodium little higher, the brain edema can come down. That when we discussed about hypernatremia, we have discussed that. Now, if you are suspecting a viral encephalitis, you don't have a diagnosis, or if you are completely convinced that it is herpes simplex encephalitis, you can start injection acyclovir 10 milligram per kg 8th hourly 2 to 3 weeks. That can be given as infusion. So remember, acyclovir should be started in all patients with suspected viral encephalitis, or if you have strong evidence like temporal lobe lesion, temporal lobe epilepsy, HSV1 positive, you can continue acyclovir. If temporal lobe lesions are not there, HSV1 PCR is negative, then there is no point in continuing acyclovir. Other viral infections, it may not work. So these are the antivirals. You can even give valacyclovir 1000 milligram TID also can be found. Now, many encephalitis, like including Japanese encephalitis, has got vaccination schedule. So, vaccines for Japanese encephalitis can be given in areas where this disease is endemic. So, that can be tried in children or adults uh, where there is Japanese encephalitis endemic area. Rabies. Normally, we don't take rabies immunization without any dog bite or cat bite. But if there is exposure for suspected rabies infection, you can give human rabies immunoglobulin HRIG 20 international unit per kg can be started. Post exposure vaccine regime 5 doses 1 ml each IM 0, that is 0 first day, 3, 7, 14, 30, 90 days. It should be given in deltoid. Post exposure immunization regime for previously unvaccinated individual. Vaccination is routinely done in person who is working in field of animal care, not routinely. So we have discussed about viral encephalitis. Most of the time we get patients with altered behavior, some neck stiffness. We can clinically make a diagnosis of meningoencephalitis. And in emergency room, we give a cocktail treatment, like we have to cover gram-positive infection, gram-negative infection, like ceftriaxone, gentamicin, or ceftriaxone, amikacin, or meropenem. Any drug can be given depending on your clinical judgment. Most of the time, we add acyclovir to the regime. If it is an endemic area for malaria, that also will be started. Immediately, before giving the antibiotic, always preferably we have to give dexamethasone, that we have discussed in the bacterial meningitis. So we can give dexamethasone, then antibiotic along with antiviral, antimalarial if that is an endemic area. But remember, after MRI finding or LP finding, if you are ruling out other diseases, you are getting only viral infection according to your CSF study pattern, you can stop all other drugs immediately, because in viral encephalitis, antibiotics will not work. Like in bacterial infection, antivirals will not work. Herpes simplex infection, acyclovir will work. Other viral infection, other viral encephalitis, that acyclovir will not work. So depending on the clinical scenario, you can de-escalate the therapy. So de-escalation of therapy is very, very important in most of these conditions after initial emergency management. Thank you.